So today we're going to talk about sciatica and nerve pain in general, sort of look at those aspects. We have talked about back pain before, but this is a little bit more in terms of what we experience in clinic in terms of people complaining about sciatica, what sciatica is, and it's the nuances around that, and then some of the management and strategies in able to deal with that condition. So what are you guys sort of thoughts about sciatica and how you find it?
For me, and it's a phrase that we both use, or we all use, sorry, it's the umbrella term, innit? You know, we talk about it a lot, and it's probably the first thing out of all of our minds when someone comes in and says, I have sciatica. It's a symptom of something, you know, it's a symptom of a disc pathology, a nerve issue, a muscle issue, whatever it might be. It's basically categorised as posterior leg pain, and then what is the overall cause? So I think for us, the big thing is to identify the initial root cause of it, and then how best to then treat it. People are really easy to self-diagnose through Google and go, "Oh, I have sciatica because Google says so," but ultimately, why? Where does it come from? What is the onset? What is the problem? And how do we best rectify that? It's not just a case of dealing with the nerve pain period, it's dealing with the actual onset of it.
Like you say, it's that posterior leg pain, but I'll have people that will mention, I've got sciatica, but they've just got some sort of nerve pain in the leg. So it might be not actually the sciatic nerve, it might be the femoral nerve. Generally speaking, they tend to think it's discy related, whereas it might not be. It might be joint related, it might be muscular related, similar to sort of when they come in and sit down and they've got piriformis syndrome, because I've Googled that. And I always think, right, okay, I'd take that on board, but have you got that? Or is it more, generally speaking, like you say, sciatica? And main thing is what's caused it. So, is it a gradual onset of injury, a sudden onset of injury, and take it from there, really.
Yeah, I mean, I often tell people you say it's a multitude, it's it's an umbrella term.
Yeah.
I sometimes just will say there's no such thing as sciatica, to be silly like as well. Actually, it's because that isn't a condition.
Yeah.
So you might have a meniscal tear. Well, that's a physical actual thing. But in terms of there's not really a specific thing. Multitude of causes, like you said. You talked about muscle and joint, but also stress is another one.
Yeah.
So I was listening to a sciatica podcast a few years ago. That's
As you do.
As you do. I was.
It's a proper geek on that.
No, I was good. I was painting at the time, so it kind of helped. Watching paint dry and listening to that was a good combination.
Yeah, literally.
But he was talking about a colleague who works in NHS, and she'd had sciatica in the past, and then every 6 months she had to do a 2-week on call. So she was a NHS sort of musculoskeletal sort of physio, and she was saying that 2-week period her sciatica would come back.
When she was on or off?
On call.
All
That
right.
2-week period. So it shows that, again, things like that are all how it's influenced, and we've got to try and work around those aspects, and as well as being an umbrella for a lot of different conditions, it's multifactorial, isn't it?
Yeah.
So sometimes when someone's coming in, I'm looking at education, management, mobility, strength, all these kind of things, because if people are looking for a magic bullet, I mean, we say this for a lot of injuries, but I think certainly with nerve type of conditions, if you're looking for a magic bullet, then you're going to be really, really sort of, you're going to struggle. I mean, we get it in clinic, we get, to be frank, I mean, you'll have had it as well. We have someone come in, horrific nerve pain, doesn't work first time, and they'll go somewhere else.
Yeah. Because they're desperate, though, aren't they? Because the pain, like says, horrific.
I had it a few weeks ago. Someone came, found us. He actually came. I was in a session, and he came just between the sessions, and I managed to get him in with one of the colleagues. And I was like, and he said he'd been somewhere else, and I was like, oh, right, here we go. I think there's going to be a red flag here. And lo and behold,
just shopping around for a quick fix.
Lo and behold, I kind of tried to preempt that with some. So there's a guy called Adam Dobson who's really good. He's now doing a course about radicular pain, which I'll explain in a minute. But he so I you know, I always use his sheets that he does. He's based up in the northeast, and it's got basically he's done an infographic of the 10 sciatica posts from Pete Sullivan, which is the research paper about the myths around sciatica. So I tried to preempt it, tried to help my colleague next week, a few days before. He just dropped me a text. I can't make it. I'll be in touch. And I'm like, all right, well,
you know,
not all that, you know, and that's, you know, like, you know, I'm not, you know, I understand it, but it's just, I think it's important for people to understand. If you're looking, you know, to be quite frank, if you're looking for a magic bullet with a sciatica condition, and the best thing about that infographic, and I always highlight it to people, is that after 12 weeks, 50% of people have resolution.
Yeah.
Which means that 1 in 2 people still have it after 12 weeks. And after 12 months, 25% still have it. And so this comes back to the management. It's about how we manage those conditions, and then as Louis Gifford, you know, we always sort of, in terms of chronic pain and pain management, always talks about that graded exposure. So our role is to get people from here to here, but gradually.
Yeah, and like you say, it's realistic as
Yeah,
well,
and
isn't
so those are some key points that I was thinking in terms of sciatica and helping people understand it. And those, you've got to be realistic. I mean, like we've talked about before, that realistic and expectation, but also it's you know, education and like anything, some people will get it, some people won't.
I was just gonna touch on that then. So you sort of touched on it, but similar to what we've spoken about in the past, that expectation. I think sciatica is one of them where that's really crucial. The expectations of people. The expectation and the individual approach to it, because we always say it, we're like a broken record, everyone's different, everyone responds to treatment different,
exactly.
all that type of stuff, but the environmental factors of each person is, like you talk about that lady there, 2 weeks time it'll come back, you know, because she does a certain thing within a job role. You've got to really understand what each person does on a day-to-day basis, which is how you can manage it. Like I said, that progressive overload, tissue tolerance, whatever you want to call it, to try and face somebody. And like prime example, there was a chap I had who gets it quite regular, but he'll only get it in winter because part of his job is gritting, and he hates the grit wagons because they're all compressive, the seats that they're sat in. He says, I can't cope with it, I need a solid seat. And as soon as he sits on it, he spends a night gritting, sciatica comes back. And it's about trying to understand how we can manage that in and around that job. When he gets called, weather changes, you know, you need to go out gritting, there's no time to prepare for it, there's no time for warm up, for rear, whatever it could be at a random time. It's being able to manage it post flare up, post onset. He understands now he can self manage it when he's due to go out gritting, what he can do afterwards, and it's purely and simply understanding him as a person, what his job role is.
And I think in that as well, like if we know it's a condition that's built up over years, whether they've only been, you know, acutely symptomatic on a shorter term, but we know that I kind of say, like you say, the expectations, you are likely to probably get flare-ups in the future, but what we want to do is decrease that severity. We want to decrease the length of time you've got that flare-up for and give you those management tools so you're not dependent on us, you know how best to manage it. Or like you say, you know, a sudden change of job or things like that are going to trigger it as well.
We talk about progression a lot, don't they? And people, again, something I say on a daily basis, people sort of come in with the idea of, am I in pain, yes or no? And that's their only gauge of progression. Whereas especially with something like sciatica and nerve pain, is it as frequent? Is it intense? Does it last as long? Is it over a longer duration? Is it as far down your leg as it has been in the past? You know, those type of things. That's an actual sign of progression, not have I got it, yes or no.
And I think like something like nerve pain is so consuming. You know, you wake up in the morning, you've got it all day, all night. But funnily enough, as soon as it starts to get easier, you suddenly forgot about it. And like you say, when you have that chat with people and you're like, oh, right, I don't know if it's better. And you think, well, I saw you 2 weeks ago, you were in excruciating pain, it was consuming you couldn't do this, you couldn't do that. And it's always like baby changes, but you're like, but actually you've made a lot of great progress.
Sleep's a massive one. I always seem to find this with people. If they're kept awake at night with it, or they wake up, they've got broken sleep, whatever it might be. Once you sort of break the back of that and they're getting a full night's sleep, generally, pardon the pun,
not literally,
a bit ill-tasted, but that seems to be, once they get that full night's sleep and they start to get that regularly, surprise, surprise, that's where everything starts.
Yeah, and the
So
body
this
starts to
comes in,
recover.
yeah, but that's what we were saying before, the stress, isn't it? So so these factors that affect it, like we should obviously talk about stress, but actually that's also a bit of an umbrella term, and you can almost break that down to sleep, diet, exercise, fresh air, nature, family relationships, work relationships, how much work you've got going on, and we can. And have you either you two had sciatica?
Yeah.
No.
Yeah. So I first had it. We're now 2025. So I had it around 2012, 2013 area at the time. Yeah, 2013, yeah. And there could have been a multitude of factors for that. And it was really bad from like the end of 20, the end of sort of like, yeah, 2013 it was. And I eventually it took me to about July the next year to properly get rid of it. So my symptoms were really bad in the morning, and by about 11, 12 o'clock, I would try and limit the medication. The one that worked for me was ibuprofen, and we can maybe talk around meds and sciatica in a minute. And then I kind of managed it, obviously you both know Rob, so I went to see Rob, and he was,
The treatment, yeah.
Yeah, and he helped me a lot and stuff, and so yeah, so I kept up with that.
And you keep on top of it now, don't you? That's
Yeah,
the thing.
exactly. But the second time was about 3 years ago, and I was kind of quite busy with the back end of my masters. So there's a period where I had like me ethics proposal to write. I had an assignment and a presentation to do all at the same time, and then I was back in Yorkshire with mum and dad. I was sort of a height like this, but the desk was like this because it's
Okay,
mum and dad's house, so everything's sort of all random. And then basically spent like 7 hours doing my ethics proposal, and it was all it's really fiddly bits to do. And then like 2 days later, the onset came on, and it took about 6 to 8 weeks. But the key thing is, and I had this conversation with someone yesterday, because he had more femoral pain, and you're making progress, and then it's had a little step back, and it's kind of a flare up, and when we kind of assessed it, potentially, because of where it is around that sort of hip area, if you can point to sort of glute med, and he'd done, the only thing he'd done differently in the gym was the step machine. And obviously, you think that's going to, obviously, when you go in single leg, and single leg is big glute med.
Yeah.
Potentially, I'll just irritate the nerve, which is fine. But the word he was worried about was damage. I've gone backwards.
Yeah.
He said he's gone backwards, and he was worried about damaging it. And I said, no, you've not gone backwards. You saw that time. So it's a graph. So yeah, you've not gone that way. The graph's still going that way. But on the dot,
It's actually
if
up and down.
we were to dot, you might have a down here. But if we were to draw a line so far, there's a progression. So you can't. So psychologically, because like you say, because it's all consuming. And that's where the psychological element of science. We don't want you to get to a point where you're like, oh, it's gone back. It's just part of the process, and how you manage that.
And as you're recovering from it, like you say, your symptoms do go up and down, because at times it's like you might have had the build up for years, like your back's really, really stiff and tight, and as we start loosening that manually, and as the person starts doing more mobility, they go through, like I say, a little bit of a vulnerable stage, because it's kind of like that spasm that might have been holding them together. It's loosened off, hasn't it?
Yeah, exactly. So it's not like, well, I mean, nothing is, but especially nerves, because if you've done your calf, you could roughly say, let's say someone's run on a Sunday, and they come and see us on a Monday with acute calf tear. We can roughly, within reason, say at 2 to 4 weeks you'll be here, 4 to 6 weeks you'll be here, etc., etc.
Yeah.
The nerve pain is not like that.
No.
And the sporadic nature is the key thing about nerve pain. And also, as well, I said about he was talking about going backwards. The other word he used about damage, and that's a dangerous word to use. So when I had this bad episode 3 years ago, I was still running on a Saturday. I mean, I look like John Wayne running around the streets, but I did it.
Do it anyway.
But I did it because I wanted to make sure that I got out and did stuff. I might be sore. I remember I did it ran on the Saturday, and we had the week after I had a concussion module, which was like a full week of being sat in uni. And I was like, I remember on the Tuesday thinking, yeah, I need to get up here, I'm quite sore. But by the Wednesday, it was kind of gone.
And that's the thing, like you say, about movement as well. Yeah.
The movement, yeah. And that is the key thing. So I think for me, those are my key things, like understanding it, don't be fearful of it, and psychology, like, you know, sort of, you've got to, it's a nerve, the nerve condition is a nerve, but actually that'll do what it needs to do, that'll heal in time. The biggest thing is you've got to get the psychology in. And sometimes I feel, I don't know about you, but I feel either in the first session or like this was maybe the third session yesterday, you're almost having to convince people that what you're saying is true. You almost have to convince them. This is, but
well, you're educating them, aren't you? But it's like, I think because they're like,
fear.
It's fear.
Well, it's fear and anxiety, and they're wanting, and if they're wanting a quick fix, or if they've had or if it's gone backwards, they're kind of like, because our job is all about trust and that therapeutic alliance. And there's so much misinformation now. When you're all telling people stuff that, like I said there, this probably will be there in 12 weeks. There's a good chance of a 50-50 chance you'll be there in 12 weeks. That's not what people want to hear. No. So it's really about trying to get people on board and just trying to be honest with them.
With that, on that, we've always lived by that. We're just honest with people, you know, and that information there going, it's not going to go over that. I always use the phrase, I'm not Harry Potter, I can't wave a wand and just make it go away. If that's what you're looking for, I'm not the person for you, but there isn't anyone out there that can do that for you, because physiologically it just doesn't work like that. And
sorry to butt in, but it is literally that, like we can do some things, but we're not like magic, like they've got to put in the work as well.
And you sort of, I think it clicks with some people. You see it, they sort of go, right, okay, fair enough, I get it, thanks for being honest with me, whatever. How do I get on top of it? Right, this is what you do. You get some people that completely backtrack, go, well, no, it's not what I want, I need it gone now because I've got an event on Sunday. It's like, well,
it's not
good luck, because that's not happening, you know. So fair play to you if that's what you think, but it isn't going to happen. But again, it's that expectation that, and the misinformation is a massive one around sciatica, which is sort of the point of these videos, really. Some of the stuff you get people coming in with, I've tried this, I've tried that, I've tried this, you're thinking, what are you doing? Like, where have you got this information from at all?
Usually Instagram or YouTube.
Instagram, which is where this is going for.
But at least ours will be more informative, hopefully.
Instagram or YouTube, but that's the idea. And I think a lot of it, what people do is they skip the simple stuff, do you know what I mean? They skip the debate, they're just the dead basic stuff, just go move. And they're like, oh yeah, but I need to sleep upside down, and so it's like, what? Do you know? It's like, do I have to sleep propped up in bed? No, if you can get to sleep, go to sleep. You know, whatever direction you need to sleep and go to sleep, just get up and be mobile. You know, and
it's funny. Well, actually, it's funny you say that, because going back to that Sciatica podcast, there's a terrible name. The guy, David, something like that, Australian guy, he was talking about. He had a consultant talking about the nerve, and there's not much blood supply there, and sort of oxygen getting to that area. So what he says is a really fancy term. It might be hard to get to, but it's got to jiggle and wiggle it. So jiggle and wiggle that nerve, which allows the blood in the air, and that gets the oxygen, gets the nutrients to it, and
allows it to slide better in its canal.
Well, it can do that as well, but just in terms of all those kind of things, it allows. And just like you said, a little movement. So even if you're only going like touching your toes, but just going to the middle of your thighs, if you can only do that, or going back to Louis Gifford, he talks about what do people, they're like that, aren't they? So he calls that thoughtful, fearful movement. So what we need to create is thoughtless, fearless movement, but what I call loosey-goosey. So you've got to just walk nice and. So loosen yourself up as you're walking.
Nice and jiggly.
Yeah, just relax your arms and breathe.
Bit of Liam Gallagher.
Just bit of Liam Gallagher. That's it. Get yourself. Probably nowadays it's the Irish guy. I've got his name. The fighter.
Conor McGregor.
Conor McGregor.
Like Conor McGregor.
Actually, he walks stiff, doesn't he? So actually, you go from Conor McGregor to Liam Gallagher. That's what you need to do.
It's like the presentation of sciatica, which we've obviously spoke about, like, you know, the posterior leg stuff, but I've often had people come in and they've not got either back pain or glute pain, and it might just be a tight calf, or it might be I've got like this weird like sharp pain around my Achilles. Like I had someone in the other day, I've not seen him for about a year, and just said, I'll be honest, I was going to another physio just for a couple of times, and I just forgot about you, and I came back, and anyway, there's a problem with my Achilles, and it's probably like 5% better, and I've been about 4 times now. So I looked, and as I was talking to him, I just thought, this is neural, this isn't your Achilles. But I thought, in my head, I'm thinking, right, neural Achilles, so I still have got to like your differential diagnosis, assess. Turns out, how's your back been feeling? Not too bad, but I previously treated him for his lumbar being really stiff, looked at his back, it just wasn't moving. Slump test positive, straight leg raise positive, actual Achilles testing fine, able to jump, bounce, no sensitivity, nothing like that. I was like, look, you're just going to have to trust me. I treated his back, give him, back mobility stuff, strengthening for his like spine, comes back. Oh, I couldn't believe it. I was like 60% better, it's still there a bit. I was like, oh, well, like, that's a good job. Yeah. But what I'm getting at is it not always your back, your sort of lumbar, sacral area, glutey stuff. It might be really tight hammy, like your hammy just keeps cramping up.
It's a common one, isn't it?
Yeah.
You see a lot of hamstrings, like,
Yeah.
and it's like, and it's, you do the test, it's like, oh, that's more nervy than it is muscular. But yeah, that's good. That's a good point. And I suppose that comes to then, when we say it's an umbrella term, it's really what sciatica is generally two main things, which is the radicular pain, which is what we kind of talked about initially, which is that kind of classic sharp pain down the leg, or very, sort of spells of sort of deep ache, like what I was having. But then it also is the radiculopathy, which is what you were talking about, where you might have some issue feeling around that area. Could be lower down the leg, or that pins and needles, which because that's the signals being disrupted. Because it's obviously it's your central nervous system, isn't it? So I use that analogy a bit like a phone signal. Yeah. So that there's a message going out from your central nervous system, the message back is disrupted.
Yeah.
So those two things, and like you said, they sometimes could be both at the same time, or sometimes one or the other.
That's a good point. Actually, we could do with touching on again. Conversation you have a lot of people say just feels weird, like just here and in my foot it feels weird. There's
like
something
a fizzing
like
or something, or a tingle.
And where people talk about I've trapped a nerve, that's always a common. I've trapped a nerve, I've got sciatica, and we talk about like what the thought process of what trapping a nerve is. And there's like, oh, it's like your nerves compressed, and I said, well, not really, because you're not getting any muscle wasting, any loss of function, anything like that. You can get an impingement on a nerve, you can get irritation to the nerve.
That's
in the canals and the foramens and facet joints, whatever it might be. But what I was trying to explain to people is you get the inflammation around the nerve root or around areas of the nerve, which changes the chemistry of the nerve, which is why the sensitivity change is different. So there's no issue with the functionality of it. You're not going to collapse, your leg's not going to fall off, you're not going to damage anything or break anything. It just feels weird. And until we can set that inflammation down, and like you said, get some blood flow, some air going around the nerve, that sensitivity will start to relax. The sort of weirdness, the fizziness will be less intense, the duration of it will be less. And again, it might, or quite often, if it's in your foot, it's probably at its worst. And the further up your leg it gets, the better it's becoming, So again, talking expectations, something I always try and describe to people is if that starts to happen, the process of the discomfort comes up your leg, see it as a positive, see it as a good thing. It comes from your calf into your hamstring, into your glute, into your back. If it's doing that process, see it as, all right, well, he said that I'm going to get better as it's doing this. The closer it's getting to the actual epicenter of the issue, the better it is, the better it's going to become.
That epicenter, so when we said about radicular pain and radiculopathy, they both start with rad, which means root, and that's what you're saying. So exactly at that nerve root, we used to talk about the sort of the neurotransmitters and the ion chains opening, and basically rather than being closed, they're too much firing.
Which is synaptic cleft.
That's it. Exactly.
Did you want to touch on medication before we finish?
Yeah, I think that's a good one. Yeah, so I think there's lots of, the class. There's different. There's always different guidelines that come out, and obviously we're not prescribers, but just from our own experience, as what obviously a lot of times now amitriptyline is given. That's one of the sort of
from the GP.
Yeah, that's one of the big recommendations that the NICE guys. So if you go to your GP, they might do that. Naproxen, which is a stronger version.
An anti-inflammatory.
A stronger version of ibuprofen, which which is
just to touch on as well, if people aren't aware, amitriptyline. So it's like it kind of depresses the nerve, because I think when people Google it, they get a little bit.
It's an antidepressant. It's an antidepressant, exactly. But so then obviously they can use it for that. And again, that can make people feel a bit odd sometimes because it is As it depends, it's going to be obviously touching the brain.
It's just like you say, just altering the chemistry because the nerve's a little bit up here. It's just trying to shut it down a little bit.
Yeah, the proxine is it's a funny one, isn't it? I mean, is it? There's some debate whether it's actually true inflammatory condition. So, but like I said, for me, actually, if I had an ibuprofen in the morning, by about 11, by sort of mid-morning, that kind of it just took the edge off.
I find that as well. If my back flares up.
Yeah, but obviously these things have side effects, and that's the key thing with it. And there was a move away from like the GABAs, so the similar sort of thing. So you got like gabapentin, for example, which again that's just attaching to the basically the GABA on your nervous system basically, and it's basically shutting that down from a neural perspective. But that was kind of the move away from that. Although saying that, I have seen it being prescribed a bit more recently. So, but again, it's your GP will. Every GP is different, but also you've got to find what works well for you and understanding your pain, your side effects, other medication. So meds have a place, but all these things
won't fix it.
They won't fix it, and they've got to. And sometimes you have to try a couple to see which works, and it's like anything, just see what.
I find as well more with the sort of longer standing clients, like supplement wise, magnesium helps as well because that helps with the neural function.
Potentially,
so I always think why not? It's worth trying.
Well, I think it's got sometimes there is an element of that, isn't it? Try see what helps. But the biggest thing is, like, while we're giving that advice, it's just you always speak to your GP.
Exactly, yeah.
I think just to summarise before we sort of bring this episode to a close, ultimately what we're trying to get at, as we always do, is it's a massively individual condition, isn't it? A certain movement might benefit you, which might not benefit the next person. Certain medication might work for you, which won't benefit the next person. So the old sort of thought process of, I'll just Google a few sciatica exercises might actually be making it worse if you don't actually understand the root cause. So whatever the issue may be, just make sure you try and understand the person, their environment, the goals, their expectations, the realistic goals.
It's that way. That's where it comes to the graded exposure. And then that's the key. So it's that's our role, is to help you through that process.
Yeah.
Yeah.
And that is Sciatica summed up.